Yeah.
Got it. All right, well, hi everyone. I am really happy to be here. This is my first time at a hepatitis B echo. I'm a hepatologist at Mount Sinai in New York and have had an interest in liver disease in pregnancy, which all was actually started with my interest in hepatitis B in pregnancy, as Jesse may remember from our times in fellowship at Penn. So I will be discussing hepatitis B in pregnancy and the different aspects that I find relevant when we think about hepatitis B in the context of pregnancy, with obviously a focus on mother-to-child transmission of hepatitis B. So these are disclosures. So I wanted to start with a quick case of a patient that I saw last week or 2 weeks ago. And this case, I think, illustrates a lot of what I'll be discussing. So this is a 22-year-old woman, and she was pregnant for her first time. She was 16 weeks gestation, no prior past medical history. She was originally from Ghana and moved to New York City 5 years ago. And she actually presented to another hospital with itching, pruritus, and yellowing of her eyes, scleral icterus. And she was actually transferred to Mount Sinai for evaluation of abnormal liver tests. She did have a urinary tract infection 1 week prior and was treated with antibiotics. So there was concern that maybe this is some kind of drug-induced liver injury or some other type of liver injury. And she denied any risk factor history, no history of blood transfusions, tattoos, injection drug use. She had not traveled anywhere anytime recently, including back to her home country. And she was sexually active with one partner. When she came to the hospital, she did have scleral icterus and otherwise looked relatively well. But then when her labs were checked here, they were quite impressive. Her liver tests were quite high. The ALT was 1531, AST over 2000, bilirubin of 8.6, and fortunately INR that wasn't too high, and she had a right upper quadrant ultrasound. So really a broad workup was done to try to figure out what is the cause of this liver injury. And on workup, she was found to be hepatitis B surface antigen positive, core IgM positive, and she was actually hepatitis C antibody positive, but RNA negative, and she had active hepatitis B. So this patient, because she was hepatitis B core IgM positive, was diagnosed with hepatitis B with concern for acute hepatitis B infection. So I will get back to the case at the end of the presentation, but we can move on to some of the issues that I think are relevant. So, when we think about hepatitis B in pregnancy, particularly in the US, I think, is more relevant to all of us practicing in the US. I think some of the aspects to think about is what is the current epidemiology of hepatitis B, particularly in women of childbearing age in the US and in pregnancy. Are we seeing more cases, less cases, and what have the recent trends been? And then when we speak to women who may be diagnosed with hepatitis B in pregnancy, how do we counsel them? What do we tell them about the influence of becoming pregnant on what happens with their virus, with the hepatitis B? And conversely, what women find probably more pressing is how does hepatitis B impact pregnancy outcomes? Will they have adverse pregnancy outcomes because they have hepatitis B? And probably most importantly is the question of mother-to-child transmission. What is the risk and what can we do to prevent transmission? And what are the current recommendations related to this for screening for hepatitis B in the context of pregnancy, as well as what are the indications for treatment of women with hepatitis B during pregnancy? So I'll cover each of these briefly. So to start with the epidemiology, I think probably all of you here are aware, as part of the hepatitis B echo, that there's an estimated probably around 2.2 million individuals with hepatitis B in the US. The NHANES estimate of 850,000 is probably an underestimate because it undersamples from patients that may be affected, such as immigrant patient populations. And we also know that the majority of hepatitis B in the US is in immigrant patient populations, probably 95%. So in the patient that I was discussing, you know, hearing that she's from Ghana already probably could have clued someone into the fact that maybe hepatitis B is on top of the possible explanations for her elevated liver tests. And you know, the good news is that since in the US we have universal immunization, all babies born in the US are recommended to have the hepatitis B vaccine. We've seen a decline since that recommendation was made in the US cases of hepatitis B. But if you look at this panel on the right, you know, the imported cases, meaning cases of hepatitis B from outside of the US, have not really declined, because in other countries and areas of the world, such as West Africa, where our patient was from, they don't have universal vaccination. So it's really something that is still a major concern in the US because of the immigrant population. And in addition, in the US, there have been some reports of increases in acute hepatitis B within the US among patients in the US related to current risk factors such as injection drug use. So this is one MMWR report that looked at the states where the opioid epidemic has shown has led to increases in hepatitis C, and they saw increases in acute hepatitis B in these states, in Kentucky, Tennessee, and West Virginia. So I think also it is important when we think about women of childbearing age that injection drug use is a risk factor, just like it is for hepatitis C. And again, here in these states, we saw an increase, but you know, the good news is that in the US as a whole, it does look like there's not an increase in acute hepatitis B infections, but in these risk populations, that is still a very relevant risk. And then how about specifically in women in the US, what are we seeing? So we actually wanted to look at this in the country as a whole, looking at data from Quest Labs. And we looked at over 8 million women of childbearing age, so women aged 15 to 44 with hepatitis B testing. And we again tried to look at rates over time from 2011 to 2017 of hepatitis B. And as you see here, nationally, there is a decline over time, which is great. But when we looked at a state-specific level, there were some states where we interestingly did see increases of both chronic and acute hepatitis B. And what was very interesting is that the states where we saw the increases also paralleled the states in that MMWR report, where the injection drug use is a big issue. And then that extends to, you know, the question of what are we seeing in pregnancy? So as many of you are probably aware, we do recommend screening of all pregnant women for hepatitis B during pregnancy, and I'll discuss that a little bit more later. But there have been nationwide studies trying to look at prevalence of hepatitis B in pregnancy. And this is a study published in 2017, and it used the nationwide inpatient sample, which is a database of inpatient hospitalizations. And of course, all pregnant women are hospitalized for delivery. So it's a good database to look at to try to assess trends over time. And from 1998 to 2011, they did see an increase in hepatitis B being diagnosed. And we looked at this recently to try to extend to more current time. And we saw that, you know, when looking from 2011 to 2019, really it seems to stabilize here. So I think that what was seen in these earlier years is probably a combination of an increase in recognition of the importance of testing during pregnancy. The more you test, the more you identify, and maybe potentially an increase in actual prevalence. But it looks like that it does appear to be stabilizing over recent years. So knowing this, and you know, when you meet women during pregnancy, what can we tell them about the relationship between pregnancy and hepatitis B? So one question is, does becoming pregnant affect what happens with the natural history of hepatitis B? And we do know that there are many immunologic changes that occur during pregnancy, and they can predispose to hepatitis B flares. And the thought is that the majority of these flares happen post-delivery because there's a phenomenon of immune restoration. So during pregnancy, you're relatively immunosuppressed, and then there's immune restoration after pregnancy, and that can predispose to hepatitis B flares. And this has been looked at in multiple studies to try to delineate, well, how common is this? How do we counsel women? Will you likely have a hepatitis B flare? Is it pretty uncommon? What are the outcomes of these hepatitis B flares? And looking at these studies, it's kind of, pretty across the board. So one earlier study said that 45% of patients, so almost half of women, will experience a hepatitis B flare as a result of pregnancy. But then others have lower estimates, ranging anywhere from 6% to 50%. And it does appear that although some only looked at the postpartum phase, some of these flares can also occur during pregnancy. Fortunately, in their review of this, the flares were found to be mostly subclinical, so it's rare that these patients ended up having hepatic decompensation. But the way that this is relevant to the case that I presented earlier is that it is a possibility that the patient that I discussed, that it wasn't actually a new acute hepatitis B infection, but rather it could have been a hepatitis B flare. Her biggest risk factor was that she's from Ghana and she hasn't been there in 5 years, but now she becomes pregnant and now she may have been experiencing a hepatitis B flare. There's no way to know for sure because we don't have prior hepatitis B testing available for her, but it is quite possible that this actually was more a flare of chronic hepatitis B than the new hepatitis B infection. So important to be aware of that as a possibility. And then what do we know about the influence of hepatitis B on pregnancy outcomes? How do we counsel women about what may happen in terms of the outcome of the pregnancy itself if they have hepatitis B? So similarly, there have been many studies, mostly from Asia, done on this topic to look to see if women with hepatitis B compared to women without hepatitis B may be at increased risk of pregnancy complications. This is data from a meta-analysis that was just recently published that tried to pool data from 27 studies and looked at all relevant pregnancy outcomes to see if having hepatitis B increased the risk of these outcomes. And what they found is that there was an association with preterm birth and gestational diabetes. Interestingly, hepatitis B seemed to be protective or have a decreased risk of preeclampsia, and there was no association with miscarriage and low birth weight. I would say that when we look at these odds ratios, they are relatively low, so it doesn't seem that it's a hugely increased risk. That being said, personally, anecdotally, I have seen patients with hepatitis B who really don't seem to have other risk factors, but then develop gestational diabetes. And there is a literature about hepatitis B having an impact on metabolic factors such as insulin resistance and inflammation. So I think the gestational diabetes association is very interesting and probably needs to be investigated more. But I think when given this data and where we are now, so many of the studies are mixed, as you see across the board, that I don't definitively counsel women that they are at increased risk of these complications, but sometimes say that, studies are mixed in terms of what they say about their risk of these complications. And finally, the issue of mother-to-child transmission, I think that is really where a lot of the focus is during pregnancy management in women with hepatitis B, and it's also the focus of the patients themselves, because they really want to do everything they can to minimize or prevent the risk of transmission. So, what's important to know, this is data from very early studies, 1975 and 1985, but without any intervention, hepatitis B is extremely transmissible to the baby. And we know that if you have mother-to-child transmission at birth, the baby has a 90% chance of developing chronic hepatitis B. So, in terms of if you don't do anything and the mother is hepatitis B e antigen positive, there's actually a 90% risk of transmission. If you have acute hepatitis B in pregnancy and nothing is done, 50% risk of transmission. The thought is that the majority of the transmission happens at around the time of delivery. And so a lot of the interventions that we do focus at that time, but if nothing is done, the risk of transmission is really high. And so that's why we have a lot of measures now to prevent transmission. So what can we do? What can we do to prevent the transmission of hepatitis B? So this is the CDC strategy. And so the first is we screen all pregnant women for hepatitis B. So regardless of risk factors, all women should be screened for hepatitis B, again, because of this high risk of transmission. So we need to know whether women have hepatitis B. Also, in conjunction with that, hepatitis B DNA testing is recommended because we know that, and I'll share just one study later on this, that the higher the hepatitis B viral load, the higher is the risk of transmission, and we tailor our interventions to that. On the infant side, when the infants are born to mothers who screen positive for hepatitis B, the infant needs to get prophylaxis with both hepatitis B vaccine and hepatitis B immunoglobulin. And in addition, universal vaccination of all infants, regardless of maternal hepatitis B status, is recommended. And of course, vaccination of adults at risk for hepatitis B infection, including those requesting protection from hepatitis B without acknowledgement of a specific risk factor. So all of these are measures recommended by CDC for the prevention of mother-to-child transmission. And in addition to that, there are additional obstetric care recommendations, and this is the guidelines from the Society for Maternal Fetal Medicine. So in addition to all those things that I mentioned, including screening pregnant women for hepatitis B and infant prophylaxis, and viral load testing, there's also recommendation to have a discussion with women about invasive testing during pregnancy, because there is some data to suggest that invasive testing, including amniocentesis or CVS, may increase the risk of transmission. So there should be counseling the women to talk about that before these procedures are done. In addition, there have been studies looking at whether there's a benefit of C-section versus vaginal delivery in terms of the risk of transmission. And when all the data has been synthesized, it is really not, there's no benefit for one mode of delivery versus another. So here it says that we suggest C-section cesarean delivery not be performed for the sole indication of reduction of hepatitis B transmission. So I had a patient just this week ask me, should I opt for a C-section because of my hepatitis B? And the answer is no, that there really is no benefit. And the last thing also that women also want to know about is about breastfeeding. And so there should not be discouragement of breastfeeding. In fact, women are encouraged to breastfeed as long as the infant receives immunoprophylaxis at birth. So what are the current recommendations? So as I mentioned already in these two guidelines, screening of all women is recommended for hepatitis B. Previously, only high-risk screening was recommended, but since then, it was not effective basically in identifying all patients with hepatitis B. So we do recommend screening of all women during pregnancy, and the recommendation was made in 1991, which probably explains some of these trends where we saw an increase in diagnosis since that time. And then the role of antiviral therapy during pregnancy is also an important question. So as the guidelines that I just showed suggested, there is an increased risk of transmission of hepatitis B with higher viral loads, even despite administration of the hepatitis B vaccine and immunoglobulin to the infant. There have been multiple studies done on the role of antiviral therapy to further decrease the risk of mother-to-child transmission. this is one study from 2016 in the New England Journal, and it looked at women with the hepatitis B DNA over 200,000 and randomly assigned them to either receive tenofovir or not receive tenofovir. And their outcome was to see whether infants had mother-to-child transmission. And it showed that there was a significant reduction in infants with hepatitis B or mother-to-child transmission in women who received tenofovir compared to women who didn't. And so based on this, as well as other studies that have been done, the guidelines really across the board, initially it was AASLD, but then also Society for Maternal Fetal Medicine agreed, as well as the CDC, that there is a recommendation to treat moms if their viral load is over 200,000 for the prevention of mother-to-child transmission. Of course, the infant will get hepatitis B immunoglobulin and hepatitis B vaccine within 12 hours of birth. But on top of that, the mom, if she meets this viral load criteria, should also be treated to further bring down the risk of mother-to-child transmission. And if all of these things are done, then the risk of transmission is really close to zero. And so we have effective ways to do this. You know, the idea is that we need to know who has hepatitis B and make sure that they're engaged in care in order to make sure all of these steps are done. So when I meet someone with hepatitis B during pregnancy, the first question to ask is, even prior to pregnancy, do they qualify for hepatitis B treatment? Because the guidelines for hepatitis B treatment outside of pregnancy also include other parameters such as the liver enzymes, right? So if they qualify for hepatitis B treatment, you know, based on AASLD criteria, then you initiate treatment even early in pregnancy. Then if they don't qualify for hepatitis B treatment at baseline, you can keep them off antiviral therapy, but you do need to recheck their hepatitis B viral load during third trimester. And if their viral load is over 200,000, even if their ALT is completely normal, that's when you would initiate tenofovir for the prevention of mother-to-child transmission. And this is one of the few situations where we can actually stop hepatitis B treatment. So if the indication for treatment is for the prevention of mother-to-child transmission, then you can discontinue antiviral therapy soon after delivery. And then very importantly, monitor the patients for hepatitis B flares, because especially if you discontinue antiviral therapy, they're may be at risk for hepatitis B flare. The treatment of choice for pregnancy still is tenofovir disoproxil fumarate. It is an effective therapy. It has been really well studied in the context of pregnancy in HIV patients with HIV. And now we have increasing data in hepatitis B patients. So that is currently the guideline recommended treatment. Tenofovir alafenamide also has been studied in patients with HIV, for example, but currently our guidelines still say TDF for pregnancy, but that probably may change, I would think, soon, because I don't see any reason why tenofovir alafenamide would be inferior in the context of pregnancy. So, and then just a quick reminder about what to do on the infant side. So depending on the baby's weight will have an impact on your hepatitis B vaccine and HBIG strategy. So this is a scenario from someone who the maternal hepatitis B status is not known. And so if your baby weighs over 2,000 grams, you administer the first dose of hepatitis B vaccine within 12 hours of birth. And then once maternal hepatitis B results are known, then you administer HBIG. Of course, if the maternal hepatitis B status was known from the get-go, you would administer both of them within 12 hours of birth. If the baby is low birth weight, then you administer the first dose of hepatitis B vaccine and HBIG both within 12 hours of birth, and then wait for the results, and the baby will get another hepatitis B vaccine 1 month after birth when the baby's a little bit bigger. But generally speaking, the recommendation is for the babies to receive the first dose of hepatitis B vaccine and hepatitis B immunoglobulin within 12 hours of birth. And I speak to the moms and let them know about that. The obstetric providers are excellent and the pediatric providers are excellent about having this done. But I think it's nice to also let the mom know that this is something to expect and to anticipate. And then I think the last point that I will address is really the importance of postpartum care. I have have had an interest in hepatitis B in pregnancy and see more and more women with hepatitis B during pregnancy, but I think one of the biggest challenges is keeping them engaged in care after delivery. Many of these women are actually diagnosed, similar to what I presented with the case, they're diagnosed during pregnancy. So sometimes I think the assumption is that this is kind of a pregnancy thing, and after pregnancy, I kind of move on and forget about it. And I really try to emphasize that unfortunately, we don't have a cure for hepatitis B now, and this is a chronic condition that you need to continue to follow up after delivery. And so I think it's really important to link the patients to care, to a liver specialist, reevaluate them for hepatitis B treatment, make sure that screening for HCC, hepatocellular carcinoma, is being done if indicated. For example, our patient from West Africa, she would meet criteria for HCC screening because she's over 20 years of age. And then, of course, always reevaluate the criteria for antiviral therapy. And very importantly, especially in the first 6 months postpartum, monitor for hepatitis B flare. So you may want to be seeing patients more frequently in those first 6 months after delivery. And studies have shown that this postpartum piece is really a challenge. So this is one study that showed that only 21% of moms with positive hepatitis B during pregnancy received peripartum referral to a specialist and hepatitis B care. But patient navigation programs may help. So there data from the New York City Department of Health, there's a hepatitis B moms project where there was improvement in appropriate postpartum hepatitis B care with a patient navigation program. So I think patient navigation and other tools really are needed to make sure that patients continue to be engaged even after delivery. Okay, so I think that ends my presentation, but I'll bring us back to our case. So she was 22, she was diagnosed with hepatitis B, and thinking more about the case, I actually think it may have been more likely this was actually a hepatitis B flare in the context of pregnancy, although it could have been acute hepatitis B. She was initiated on tenofovir while she was in the hospital, and her numbers actually really improved pretty rapidly. Her liver enzymes went from the thousands to almost normal range. And then I saw her 3 months later, and in this third trimester where her viral load was now less than 20 and her liver tests were normalized. So I was very happy to see that prior to delivery, her viral load was less than 20. And of course, the first question she asked me is, when can I stop the tenofovir? So I said, definitely not yet, please. So hopefully she continues it at least until delivery and probably thereafter as well. So this is just a summary. I think nationally hepatitis B is on the decline because of all of the national measures such as universal hepatitis B infant vaccination. But, I think there are some groups that we need to continue to be aware of among women of childbearing age, those from immigrant patient populations, as well as injection drug use is emerging as also a risk factor for acute hepatitis B in young people. Hepatitis B flare can occur during pregnancy and postpartum. So usually they're subclinical, but the patient that I mentioned, that if that was a flare, that was pretty severe. Hepatitis B is associated with increased risk of pregnancy complications such as gestational diabetes and maybe preterm birth. The data is really mixed, but I think that, it is, in my counseling, I do talk about how there are many studies looking at this and there may be an increased risk of things such as gestational diabetes. There is a very high risk of mother-to-child transmission of hepatitis B if no measures are taken. So that's why it's very important that we screen all women for hepatitis B in pregnancy and then the infant gets hepatitis B vaccine and HBIG within 12 hours of birth. And then on top of that, maternal antiviral therapy if they have a high viral load. And then I think the last important piece is this postpartum piece. I think it's really a big challenge to make sure that we link patients to care after and keep them engaged, especially in that postpartum period where there's a new baby, there's so many things going on in their lives. It's really a challenge to have them prioritize their own health. And I think we need really an emphasis on this time to make sure that they're not just coming back to you next time they're pregnant. Okay, and I think that is it.
Great. Thank you so much. I know we do have time for a couple of questions, and we have one that came through in the chat box. Do you see high false positivity of HBsAg in pregnancy?
I would not say I see high false positivity, but I have seen a few. You know, sometimes someone comes with a positive surface antigen, they have no risk factors, and then you check their other serologies and their core antibody is negative, which, you know, doesn't make sense. So then I just retest, and then I see it, you know, if their viral load is undetectable and their core antibody is negative, it's pretty unlikely that they have, you know, active or chronic hepatitis B. I've seen a few, but I haven't seen it very much.
Great, thank you. Is there any other questions on the didactic?
I was going to ask a quick question. Thanks very much for the presentation. You mentioned in your algorithm from your clinical liver disease article about staging for fibrosis in pregnancy, and I was just curious how you approach that. Most of us are not doing elastography in pregnant women. Just curious what you do.
Yeah, so elastography is, to my knowledge, still not approved in pregnancy. I really don't understand why, because I don't really see a reason why it would be, but I think everyone's just scared of pregnant women and any intervention in pregnant women. But yeah, so we can't do elastography. I mean, you know, you can use, you know, serologic tests like FIB4 and a pre, and that's probably the best that we have. Or even sometimes I do send like a fibro test. But the truth is none of those are validated in pregnancy. So to me, probably the most helpful is getting an ultrasound and, you know, in conjunction with the labs to see, you know, do they have a nodular liver with splenomegaly? Obviously that would be concerning. But I think the best we can use is really serologic tests because FibroScan is not approved.
Thanks.
Thank you. And then we had another come through in the chat. Is there a recommendation to treat women in pregnancy if they had a previous child test positive for hepatitis B?
Oh, that's a great question. I think that you would still base it on the viral load and you know, basically I think I would still follow the guidelines, but I've never had actually that situation. I'm curious if anyone else has. I mean, I think you can have that discussion probably to say, you know, clearly something, you had some risk factor for transmission, but I think it would also be curious to then look at, if possible, what was their viral load during that prior pregnancy. You know, if the viral load was super high last time, but this time it's, you know, less than 20 or, you know, low hundreds or something, then it's a different scenario. So I think we're pretty confident in saying that the most important risk factors for transmission are viral load, you know, e antigen positive status, which is related to viral load. And those are the things that probably I would go by.
Jesse, go ahead. I see your hands up.
Touching on that was amazing. Thank you so much for the presentation. I am wondering, since we have so much expertise on the panel here and with everybody in the audience with patient navigation, I'm wondering if the patient navigators could comment on some of the barriers to keeping these women in care or getting them into care in the first place, and if there are common themes with those barriers.
It's a great question. Thank you for
asking. That's a great question.
Let's see. I think I know some of them. Feel free, our patient navigators. I saw someone from New York on the line. Liz Tang, if you wanted, I know you have been involved in the Hep B Moms program. And then Tanaja too, I know you're at the PDPH if you guys have any experience.
I've mostly had experience with Hep C moms for Peri C, but it pretty much goes the same way of just following up with them and making sure that they are continuously engaged. And of course, Hep C is a lot shorter time frame of follow-up, but just staying on top of everything and making sure that, you know, we're actively engaged. We also had some like incentives and things like that. And I know that sometimes it's not really sustainable, but it can definitely be helpful to keep them engaged.
Hi, everyone. I'm Liz Ted. I'm from New York City Health Department. So I work with people living with hepatitis B, and especially people during pregnancy and also in the postpartum period. So I would say, we also work with C cases, Hep C cases for linkage to care and supportive services in our team. So compared to C patients, I think from our experience, for B cases, very likely and many times we have to hold the case for a longer time because patients usually has more barriers or challenging around health insurance, especially because we work with people who are in post-spectrum. And then many of them in New York City, when they're pregnant, they use a temporary Medicaid, and then the insurance got disconnect, like got terminate like 2 months after. So we have to really help the patient to try to see if they are eligible for any other insurance or get into the H&H hospital, that is a public hospital by the city, and they have sliding fee scale, low cost or even no cost at all. So there are different things going on. Sometimes they have problem with childcare. So what we do is we also have like contact with, so other than the public hospital, we also have contact with the organizations that they can help people to enroll into insurance. So in case people, if they don't want to go to public hospital and then they still have a choice that they can get insurance and then go to somewhere else. And also health education is a big thing, I would say. Many people in our Happy Project, they are willing to stay on the line and really try to understand what's going on. And especially for the project that we work on, the patient has a newborn baby at home, so they really care about transmission. So I think health education is one thing that they really care about.
Thank you so much, Liz and Tanaja, for your input on that, and great question as well. Just in the interest of time, I know we're running a little bit behind today, but I think we've had some great discussions. If you have other questions, just pop them in the chat box and we'll try to get them at the end, or we can get them after the session. We have our case presentation